Hi everyone, I'm Dr. Ilajan Khandelwal and I'm back again, and in this module what I'm going to discuss with all of you is the pathology questions which were asked in the INI CET May 2022 exam, right? If you ask me the overall gist of the exam, students, the paper was fairly simple, more on the lines of previous year questions, right? One or two questions were bouncers, but except for that, if you have read pathology thrice at least and done a lot of MCQs, I'm sure you would have done the paper fairly easily, right? What we also observed is a lot of clinico-pathologic scenarios were asked and many questions were asked from anemias, as is the case with the exam pattern most of the time, right? Now let us start with the first question. This was: blood transfusion requires screening of donor blood for all of the following infections except, right? Remember students, in blood banking, I told you whenever we take blood from any patient, before transfusing it to any person, what we do, we have to screen the blood for 5 things, right? What are the infections? We talk about hepatitis B, hepatitis C, malaria, HIV and syphilis. So we screen the blood for all these 5 infections because these are commonly blood transmitted infections, and then students, we transfuse it to a recipient, right? So here they asked you that which infection out of these is not screened. Malaria is definitely screened, HIV is screened, dengue is not screened, hepatitis B is screened. So this was a fairly easy and straightforward question. The answer was dengue. We do not screen dengue fever because it is not an infection which is usually transmitted by blood, but we screen these 5 things, right? Next. A 15-year-old boy presents with a swelling in the upper diaphyseal part of the tibia. There was a periosteal reaction. A biopsy was performed. The histopathological image is shown below. The IHC was found to be synaptophysin and MYC2 positive. What is the most likely diagnosis? My God, there are so many keywords and clues which the examiner has given you. The first one, always start with the age. A 15-year-old boy with a diaphyseal tibial tumor, right? Periosteal reaction. Then the IHC showing synaptophysin and MYC2 positivity. And when you see this image, can you see, students, beautifully some small round blue cells forming rosettes? This is one rosette, this is another rosette, right? So what are these structures which we see? These are the rosettes. When you see this kind of a profile, what do you guys think of? Don't you guys think of one bone tumor, students, that is Ewing sarcoma? Remember, in the IHC markers table, I told you MYC2 or CD99 is a marker for Ewing sarcoma, right? So here the answer is Ewing sarcoma. I can also ask you, what is the translocation which can commonly be seen? So the translocation is T11:22. Another thing which they can give in the keyword is the X-ray. The X-ray of Ewing sarcoma shows an onion skin or an onion peel appearance, right? Because of periosteal reaction, there is an onion skin appearance or an onion peel appearance. Easy story, students. All the points are keywords in this clinico-pathologic question, and they all are leading you to the diagnosis of Ewing sarcoma. Remember this table which I showed you in the bone tumors category. See the points for Ewing sarcoma, usually seen in children less than 20 years of age, usually in diaphyses of long bones. Everything is fitting. Translocation is 11:22. X-ray will show onion skin appearance. Microscopy will show small round blue cells with rosettes, right? Everything is fitting. And the marker is MYC2 or CD99. That is one of the very good markers. That is why this is the diagnosis which I come to, right? Then students, this is also belonging to a category which is called as a small round blue cell tumor. There is a long list of small round blue cell tumors of childhood which is very frequently asked, especially in the AIMS and the INI CET exam. One of the favorite topics. So you should know neuroblastoma, retinoblastoma, hepatoblastoma, medulloblastoma and nephroblastoma. That means all the blastemal tumors, and usually in the childhood they are small round blue cell tumors. That means when you see them on microscopy, you will see sheets of small round blue cells with scanty cytoplasm along with some flower like structures which are called as the rosettes. In addition, rhabdomyosarcoma, Ewing sarcoma or peanut and lymphoma, they are also small round blue cell tumors. Easy, students. I hope now you will not mark the question incorrectly. Let us see the other options which were there. One was osteosarcoma. Is the age of osteosarcoma? Not commonly. On biopsy, osteosarcoma will show new bone formation in the form of a lace-like fashion. So this is totally wrong. CLL will show lymphoid cells. This is totally wrong. Malignant neuroblastoma. Okay, some students got confused with neuroblastoma. Will neuroblastoma usually occur in the diaphysis? No. Will neuroblastoma be MYC2 positive? No. That is why neuroblastoma is also not the answer. The best answer here is Ewing sarcoma. Correct? Next question, students. Which of the following features is not observed in a pleomorphic adenoma? Some students got confused in this question. One option is a myoepithelial cell, one is a keratin pearl, one is a chondroid differentiation, another is a perineural invasion. They have asked you what is not seen in a pleomorphic adenoma. First of all, let me tell you some important points about pleomorphic adenoma. You all know it is one of the most common salivary gland neoplasms. It is usually a benign tumor. And which gene is usually implicated, students? It is called as a PLAG1 gene can be affected. What is the name? PLAG1, right? Microscopically, it shows a triphasic pattern. That means 3 different types of components can be seen. That is why it is called pleomorphic. Multiple patterns can be seen. You can see ductal component or the tubules and the epithelial and the myoepithelial cells. Then the stroma which we usually see is myxoid or hyaline or chondroid, right? So, chondromyxoid stroma or hyaline stroma, right? For example, students, in this picture, can you see this stroma which is there? This stroma is hypocellular chondromyxoid stroma. You can see these cells, these are the myoepithelial cells and this is the ductal cells. So, this is a slide showing a pleomorphic adenoma. Understood? Now, let us go back to the question. They have asked you what is not observed, right? Myoepithelial cells we definitely see. Keratin pearls, okay. Now, sometimes this pleomorphic adenoma can show squamous differentiation, and in that case you can see keratin pearls. So, they can be seen. Chondroid differentiation can definitely be seen. Chondroid myxoid stroma can be seen, right? Last is a perineural invasion. Now, according to me, this is the best answer because this is a benign tumor which we have. Pleomorphic adenoma does not show perineural invasion. That is why this is the best answer. Can you name 2 tumors in pathology or medicine or surgery which show perineural invasion? The answer is a adenoid cystic carcinoma, which is another salivary gland tumor which shows perineural invasion, right? Adenoid cystic carcinoma. Second is the pancreatic carcinoma. Both these tumors are notorious for causing perineural invasion. It is not seen in pleomorphic adenoma. That is why this is the best answer in this question. Easy? Okay. Next. All of the following are caused by the lethal strains of HPV except, right? Lethal strain, that means the damaging or the carcinogenic strains of HPV, correct? Now, what are the carcinogenic or the lethal strains? They are HPV 16 and HPV 18. They are the more dangerous strains of HPV, HPV 16 and HPV 18, right? They are the lethal strains. And you all know, students, lethal strains can cause cancers. Which all cancers am I talking about? Cervical cancers, anogenital cancers, oral cancer. So, these days all of these cancers are usually caused by the lethal strains of HPV. What are the non-lethal strains? Remember, the low risk HPV, they are HPV 6 and 11. They are low risk HPV and they are notorious of causing genital warts, also called as condyloma acuminatum, right? So, they have asked you the question, which of the following are not caused by the lethal strains? Cervical cancer is definitely caused, anogenital cancer can be caused, oropharyngeal cancer can be caused. Which cancer is not caused? Answer is a laryngeal papilloma. Papilloma, students, is basically a benign lesion, a warty lesion, right? So, papilloma cannot be caused by a lethal strain. That is why this is the answer. Simple, right? So, HPV these days, students, is a very frequently asked topic, right? We have covered it in great detail. You know, there is low risk HPV, there is high risk HPV. What I also want to talk about is whenever you have HPV infection and a slide comes to you, the slide will show you something which is called as a coilocyte. What is a coilocyte? It is a large cell with thick membrane and a raisin-like nucleus, right? So, this is the cell with a thick membrane. The membrane is quite thick. The nucleus is raisin-like and there is a halo or an empty space around the nucleus. So, we have a empty space around the nucleus. Empty space around the nucleus. Correct? So, what is this, students? These are basically called as the coilocytes. And whenever we talk about HPV infection, we talk about coilocytes. Easy? Next question. Cell and cell appearance is seen in. Now, some students said, ma'am, we did not read about it, we don't know. Simple, students. I would have answered this question by exclusion. Is cell and cell appearance seen in necrosis? Have you ever read about it? No. Is it seen in apoptosis? No. Is it seen in necroptosis? No. Is it seen in entosis? Of course. When all the three options are not fitting, the best option is the one you don't know about. It is entosis, right? So, what is cell in cell appearance? It is seen in entosis because I know it is not seen in necrosis, apoptosis or necroptosis. Entosis, right? What is entosis? One cell engulfing the other cell, right? So, suppose this is one cell, suppose this is another cell. When the cell engulf the cells, one cell engulfing another cell, it is called as entosis. So, basically it will create a cell in cell appearance. The most closest DD of this entosis, students, is emperipolysis, right? That is something which you need to know about, and a lot of MCQs, and this image can also be asked in your paper. What is emperipolysis? It is also a cell within a cell appearance, but the important point here, student, is that the cell which is there inside, for example, this cell, this is basically viable. This is an active or a viable cell, and this viable cell can move out of the original cell also without any structural or morphological damage. So, it can exit without any structural or morphological change, right? This inside cell remains viable. It can exit without any structural or morphological change, and it is usually seen in Rosai-Dorfman syndrome, hematolymphoid disorders or non-Hodgkin's lymphoma, right? In entosis, the cell which is inside is initially living, but later on it dies. But in emperipolysis, this is a living cell which without any structural or morphological damage can move out of the cell. Right? Understood? So, now you will be able to answer all the questions related to emperipolysis also. You all know what is entosis. Understood? Okay. Let's move to the next question. Which of the following is a NK cell marker? Again, some students said this was confusing. Why was this confusing? Was because whenever we talk about the markers for NK cell, we talk about these two markers, CD16 and CD56. And unfortunately, CD16 and CD56 were not there in the options in this question, right? So, they asked you which of the following is an NK cell marker. One option is a CD3. I totally rule out CD3 because CD3 we all know is a pan T cell marker. So, this option is incorrect. CD68 is a histiocytic marker, right? That is also an option I have ruled out. Now my students were confused between CD94 and CD25. Remember students, I told you, suppose this is a NK cell, there is an inhibitory receptor or a marker on these, and that inhibitory receptor is CD94. That is basically the inhibitory marker on the surface of NK cell. That is why the answer here is CD94. It was a question in which you had to apply slight bit of a concept. That is why the answer here is CD94 and not CD25. Understood? Why? Because CD94 is basically an inhibitory receptor or a inhibitory marker which is present on the surface of the natural killer cell. Right? Easy story. Next, which one of the following is correct for the laboratory diagnosis of anemia of chronic disease? Which is the correct statement, right? Before I go to the options, let me tell you something about anemia of chronic disease. Remember students, I told you in which conditions do you see anemia of chronic disease? Whenever my patient has got chronic diseases like chronic infections, chronic neoplasms like Hodgkin's lymphoma or multiple myeloma, chronic inflammatory conditions like rheumatoid arthritis is a very common one, or TB, right? In all these conditions you can see anemia of chronic disease. What is important for you people is the pathogenesis. So they say that in chronic infections there is increased level of cytokines like IL-1, IL-6, right? When the level of these cytokines increases, it increases the level of this molecule called as hepcidin. And we all know that hepcidin is a negative iron regulator. Whenever the level of hepcidin increases, it will decrease iron and vice versa. So this increased hepcidin will lead to decrease iron and vice versa, right? So iron will decrease and therefore my patient will develop anemia. So if I ask you what is the most common molecule implicated in the pathogenesis of anemia of chronic disease, the answer is going to be hepcidin. Why is it called hepcidin? Hep means hepatocyte. It is produced by the liver, right? Also, you all know it is also an acute phase reactant. So, whenever there is inflammation or infection, the level of hepcidin might increase. It is also the master regulator of iron metabolism. So, my body has a very good mechanism. Whenever the iron deficiency is low, what it will do? Hepcidin level will also go down so that the iron level increases, right? Now, once in the INI CET exam, the question was hepcidin will act upon which molecule? This was asked last year in INI CET. This hepcidin, it acts upon ferroportin. It will act upon ferroportin. Now, what does ferroportin do? Ferroportin will lead to release of iron. So, it will degrade the ferroportin, the iron will not release, so there will be anemia, decreased iron will be there. Understood? So, which is the molecule on which hepcidin is acting? The answer is going to be ferroportin. This was asked last year. Now, you have the question, what is correct for the lab diagnosis? One option is serum hepcidin low. Is serum hepcidin low? No. So, this is an incorrect statement. Next is serum ferritin is decreased. No. The serum ferritin, because hepcidin is acting on ferroportin and iron cannot be released, so iron stores will keep on building up. That is why serum ferritin is either normal or increased in case of anemia of chronic disease. So, serum ferritin is decreased, that is also low, it is normal or increased, right? See this table students which I have created for the DDs of microcytic hypochromic anemia. We have iron deficiency anemia, sideroblastic anemia, anemia of chronic disease and thalassemia. You already know that in thalassemia everything is normal except for HbA2 level is increased, right? Iron deficiency anemia, of course, serum iron will be low, serum ferritin will be low, TIBC will increase, peripheral smear will show pencil cells. In anemia of chronic disease, the serum iron is decreased. Why? Because hepcidin is increasing. Serum ferritin increased or normal, I have already told you. TIBC is also decreased. The iron binding capacity, right, that is also decreased. So, what is the next option here? Total iron binding capacity is increased. No, the TIBC is low in anemia of chronic disease. So, what is the answer? The transferrin saturation is decreased. Of course, when iron is low, the transferrin saturation will also be low. So transferrin saturation is decreased. That is the correct answer, right? So now you know how you can utilize my tables and answer such questions. This was a slightly tricky question if you would have not understood anemia of chronic disease thoroughly, right? So the answer here is transferrin saturation is decreased, correct? Next question. All of the following are examples of age-defining malignancies except, literally a medicine question, students, age-defining malignancies. Again, you can do this question by exclusion. Non-Hodgkin's lymphoma, does it happen in age? Yes, it happens in age. Primary CNS lymphoma is a very common lymphoma. Melanoma? No. Kaposi sarcoma is one of the most common malignancies which is seen in AIDS patient. Invasive cervical cancer can also be seen. So by exclusion, a very common neoplasm which does not happen because of HIV or is not a age defining malignancy is a melanoma, right? That is the answer. Easy? Next. Neurosecretory bodies are seen in all except. Okay, so where do we see neurosecretory bodies, students? Wherever there is a neuroendocrine tumor, I will see a neurosecretory bodies. What are the neuroendocrine tumors which we talk about? A neuroendocrine tumor can be a pheochromocytoma, a carotid body tumor, a paraganglioma, right, a medullary carcinoma of thyroid, even small cell carcinoma of lung, right. All of them are neuroendocrine tumors, so they might show neurosecretory bodies. Now they are seen in all except, that means you have to rule out one option which is not a neuroendocrine tumor. Medullary thyroid cancer, it can be seen. Pituitary adenoma can be seen. Paraganglioma can be seen. Adrenal cortical tumor. So according to me, they are not seen in an adrenal cortical tumor because adrenal cortical tumors are not a neuroendocrine malignancies, right? Next, which of the following is an example of a X-linked dominant condition, right? Now, in the NEET Pathology, NEET paper 2022, there was a question which of the following was not a autosomal recessive disorder. Here we have a question which of the following is an example of a X-linked dominant condition. Why I keep on repeating is because in the MCQ exams, very commonly they ask a question on the examples of all the 4 Mendelian modes of inheritance, right? So here, which of the following is an example of X-linked dominant? For that, you people remember I told you mnemonic Ravi, Rett syndrome, A for Alport syndrome, V for vitamin D resistant rickets and I for incontinentia pigmenti, right? So what is the answer? X-linked dominant? The answer is going to be Rett syndrome. Huntington disease, the mode of inheritance is autosomal dominant. Remember the mnemonic? He has a very dominant father, right? H for Huntington's. Sickle cell anemia, autosomal recessive. Hemophilia A is a X-linked recessive disorder, right? Let us see the various examples, students. X-linked dominant, I have already told you Ravi is the mnemonic. The mother can give the disease to both sons and daughters, but father can affect only daughters and not sons. That's a very important logic which you need to take home. Then, autosomal dominant, I have already told you, he has a very dominant father. That is the mnemonic which you need to remember, right? Then autosomal recessive, the mnemonic is A, B, C, D, G, H, I, E, F, G, H, I, correct? That is the mnemonic. All the enzyme deficiencies like glycogen storage disorders or lysosomal storage disorders, sickle cell anemia, phenylketonuria, alpha-1 antitrypsin deficiency, thalassemia, all of them are autosomal recessive, right? Then we have X-linked recessive, that the mnemonic is also very important. Lady Harding college girls don't care about foolish words. Another very important mnemonic that you need to know of, right? Of course, there will be history of males much more commonly affected than females. Females are usually carriers, right? So, all these are the examples which you need to know of, right? Next, match the tumors in column A with the genes in column B. Pleomorphic adenoma, we just did PLAG1 gene is affected. So, we are matching 1 and D, correct? Burkitt lymphoma is associated with CMYC. Remember I told you? So 2 is associated with C, right? Neuroblastoma, N for neuroblastoma and N for NMYC. So NMIC. So 3 is with B. Retinoblastoma of course is with A, 4A. So we have 1D, 2C, 3B and 4A. That is why this is the answer. This is a direct mugging up question from the tables which I give you in neoplasia students. One table is on oncogenes and another table is on tumor suppressor genes. These are the two tables and they are very, very important. They can used in pathology, medicine, surgery questions anywhere students, and any type of question can be asked, right? Let us quickly revise these tables. CKIT associated with GIST, RET on chromosome number 10 is associated with medullary carcinoma of thyroid and MEN2. Again a very potential question. ALK gene can be associated with ALCL, adenocarcinoma of lung and inflammatory myofibroblastic tumor. ABL associated with CML. KRAS colon and pancreatic. HRAS bladder cancer. NRAS melanoma. CMYC Burkitt lymphoma. LMYC small cell lung cancer. NMYC neuroblastoma. Notch gene is associated with ALL, usually TALL. Easy? These are the oncogenes. Then students, we have the tumor suppressor genes. RB, chromosome 13q associated with retinoblastoma and osteosarcoma. INI CET paper 6 years back, direct question was, patient had RB gene mutation, one lesion was retinoblastoma, what is the other? Answer was osteosarcoma. P53 chromosome 17p Li-Fraumeni syndrome, NF1 neurofibromas, meningiomas and optic nerve gliomas, NF2 schwannomas, BRCA1, BRCA2 you all know associated with breast and ovarian cancers, WT1, WT2 chromosome number 11 Wilms tumor, P10 on chromosome number 10 endometrial cancer, prostate cancer, von Hippel-Lindau again very important, chromosome number 3 clear cell renal cell carcinoma and cerebellar hemangioblastoma, adenomatous polyposis coli, chromosome number 5 associated with familial adenomatous polyposis. Very, very important, right? Next question. Which of the following is not a part of the innate immunity, right? Alpha defenses, B lymphocyte, delta, gamma T lymphocytes and lectin pathway. Which is not a part of innate immunity, students? Again a direct question. You all know innate immunity is basically comprised of what kinds? The skin epithelial barriers, right? Adaptive immunity is mostly composed of B and T lymphocytes. So, which is not a part of innate immunity? The answer is the B lymphocytes, because B lymphocytes for sure are a component of the adaptive immunity and not a component of the innate immunity. Correct? Next. Identify the cell marked in the image below. Now, many students told me that, ma'am, the question was, what is the stain for mast cell? This question was asked in INI CET exam 2 years back also. Directly, students, the answer for the stain for mast cell is toluidine blue, which is a metachromatic stain. Some students told me that they marked the question, they marked the cell, sorry, and they told that this is a toluidine blue stain. What is the cell? The answer was, this is a mast cell. Can you people identify this cell which has got these bluish granules in the cytoplasm? So, this is basically a mast cell stained with toluidine blue stain, right? Which of the following statement is true about clear cell renal cell RCC? The right, clear cell RCC. It contains glycogen and lipid. Now, the clearing in clear cell RCC, if I talk about the clearing which we see is because of glycogen and lipid. That is why these cells are PAS positive and these cells are also oil rado positive. So, this is a true statement. Mostly sporadic, this is also true, right? Due to deletion of chromosome number 3q, that is also true. VHL gene on chromosome number 3q is usually deleted. Arises from DCT, that is false because it arises from the PCT. So, which is a correct statement, students? Answer is 1, 2, 3. That is the correct statement. Very good question, students, right? Few things about the 4 types of RCC which are frequently asked. One is the clear cell renal cell carcinoma, which is the most common type, usually associated with deletion of chromosome number 3p, and that is basically VHL gene is associated, von Hippel-Lindau gene, and which part of the kidney is usually affected? The proximal convoluted tubule. When you see histopathologically, students, we see cells which have clearing. The clearing is usually due to the presence of both glycogen and lipid. That is why these cells are PAS positive and Olredo positive, right? Then we have papillary RCC, can be associated with hereditary papillary RCC syndrome. CMET mutations are commonly seen, right? It usually involves PCT more commonly. Samoma bodies can be seen in any papillary tumor. So, when you see the histopathology, you will see papillae, that is why this is called as a papillary lesion. But the papillae are not lined by a fibrovascular core, students. The papillae are lined by foamy histiocytes, or they are lined by foamy macrophages, right? Then also we see Samoma bodies, and this is associated with long-term dialysis. That is another MCQ. Which type of renal cell cancer can arise in a dialysis patient? The answer is papillary, correct? Then students, the third type is called as a chromophobe renal cell cancer. Loss of multiple chromosomes like 1, 2, 6, 10 and 13 can be seen, can be associated with Birt-Hogg-Dube syndrome. Histopathology will show plant-like cells with a raisin-like nucleus, right? They are cytokeratin positive. A stain which is important here is called as the Hales colloidal iron. Which stain is important, students? Hales colloidal iron, and this type has the best prognosis. The worst prognosis is that of collecting duct or Bellini duct cancer, which is the least common type of kidney cancer, correct? So, next question is, what is the name of technique shown in the image below? This was a very straightforward question, students. Which technique is this? Can you see red and green signals? So, whenever we have red and green signals, that is the fluorescent labeled signals are there, the technique which is there is the FISH technique, fluorescent in situ hybridization, right? So, when do we use this technique, students? Whenever we know the problem, we understand. So, suppose my patient has got T9:22, right? You are suspecting my patient has got CML, translocation 9:22. You will create probes which are, you will label them with red and green signals, right? And then you will fuse and then see whether translocation is present or not. If they are fusing with each other, for example, in this image, can you see red and green signal fusing with each other? That means there is translocation, right? So, whenever you see this kind of a phenomena, it is translocation. And which technique is this? It is fluorescent in situ hybridization. This is the normal fish in which you see 2 red signals and 2 green signals, right? Normal fish. I have already told you translocation. Here you can see 3 red signals. So, what is this? This is basically a trisomy because I can see 3 red signals. In this image, can you see only 1 green signal? Here I have 2. So, what is this, students? This is monosomy, right? Then students, here, can you see amplification? Red signal is amplified, red is HER2/neu. So, this is called HER2/neu amplification, important in cases of breast cancers. So, this is about the FISH technique which you need to know of, right? Let's move to the next question. Differential expression of a gene depending upon the parent of origin is a feature of, right? Simple, students. Depending upon the parent of origin, if there is differential expression, what is this called as? Remember, we read about a technique called as genomic imprinting, not a technique, a mode. Genomic imprinting. So, what is this which we are talking about? Differential expression, it is called genomic imprinting. If I ask you, students, what is imprinting? Imprinting means silencing, right? Silencing. So, they say normally in all of us, we have 2 alleles, one coming from father, one coming from mother, maternal and paternal. They say normally also one allele is imprinted or silenced, right? And this imprinting occurs by the process of epigenetics, right? So, one is silenced. If one allele is silenced, that means only one of the allele is active. Now suppose there is a problem and the other allele also becomes defective or deleted. What will happen? My patient will get some disease, and the two well-known disease from imprinting are the Prader-Willi syndrome and the Angelman syndrome. The two well-known diseases are the Prader-Willi syndrome and the Angelman syndrome, both on chromosome number 15q. Correct? Easy? So this phenomena is called imprinting. Let us see the other options and then I will tell you something about imprinting. One is gonadal mosaicism. Mosaic is basically formed by the fusion, right? So it is basically post-zygotic fusion, that is not there. Anticipation. What is anticipation, students? They say that the severity of disease increases with each progressive generation. So if the disease severity was X in the first generation, it is 2X in the second generation, it is 3X in the third generation, and so on. So they say sometimes the severity is much more in the progressive generations. That is called as anticipation. It is usually shown by the disease which are inherited in a trinucleotide repeat manner. Correct? For example, Fragile X syndrome. Last is incomplete penetrance. What is incomplete penetrance, students? Incomplete penetrance means usually shown by autosomal dominant disorders. That means the defect, the genetic defect does not penetrate the gene completely, therefore morphologically does not manifest fully, right? That is called incomplete penetrance. So here the direct answer is genomic imprinting, which is silencing. So we have two syndromes, one is called Prader-Willi, one is called Angelman, both on chromosome number 15. In Prader-Willi there is P for Prader, P for paternal deletion. In Angelman there is maternal deletion. Now if paternal is deleted, there is disomy of the other one. So there is maternal disomy. In Angelman there is paternal disomy. But Prader-Willi is associated with SNORP gene. Angelman is associated with UBE3A gene. Easy, students? These are the two syndromes on which other questions can also be asked, right? Okay, next. Match the microscopic appearance in column A with the type of tumor in column B. Schiller dual bodies. Remember, this is a one-liner. Schiller dual bodies are seen in which tumor? They are seen in Yolk Sac Tumor. So I have matched 1 with C, right? Presence of teeth here, very easy, Teratoma, right? So I have matched 2 with D. Signet ring cells, let's leave. Col-Exner bodies are seen in granulosa cell tumor. So I have matched 4 with B, right? And I have matched 3 with A. So 1C, 2D, 4B and 3A. What is the answer? It is D. A very, very important and easy question, right? I keep on telling about these various things or the microscopic features of the various male and the female genital tumors, right? Let us quickly revise them, students. In this germinoma, there are nests of cells. You see these nests of cells, and they are divided by these fibrous septa. These fibrous septa are infiltrated with lymphocytes, right? And the cells are large polygonal with a central nuclei. Next, choriocarcinoma, you all know it's an extremely hemorrhagic and necrotic tumor showing two types of cells, the syncytiotrophoblast and the cytotrophoblast. Two kinds of cells are seen, and then a lot of areas of hemorrhage and necrosis are seen. It will be beta HCG positive, correct? Then we have Yolk Sac Tumor. This will show a Schiller dual body, also called as a glomeruloid bodies, because we see a structure like a glomerulus. How do we say what is a Schiller dual body, students? Can you see a blood vessel? Tumor cells are present around a blood vessel. Then there is some central space, and then there is another layer of cells. So that is called as a Schiller dual body or a glomeruloid body. Do you know of any other place in which we see glomeruloid body in pathology? Glioblastoma multiforme. Two glomeruloid bodies in pathology, glioblastoma multiforme and Yolk Sac tumor. Next, teratoma, any tumor which is showing hair, cartilage, teeth, bone, cystic. Think about a teratoma because it has derivatives of all three germ layers. Then, when you see the image, histopathological image of a teratoma, for example, in this slide, can you appreciate this is fat, this is some cartilaginous tissue which is seen, this is some glandular tissue, this is some epithelium, here we have a hair follicle. When you see this mixed pattern, answer is a teratoma. Next, a granulosa cell tumor. What will a granulosa cell tumor show, students? It will show some nests. Can you people appreciate these are the nests of cells? These are the nests which are seen. And then students, can you people appreciate, in this image you will be better able to appreciate, students, these bodies which are arranged like a flower, something like this, and in this flower there is a pinkish material which is there, right? Now see this, go back to this. Can you people appreciate these bodies? What are these bodies, students? These are basically the Coll-Exner bodies which are seen in granulosa cell tumors of the ovary, right? These are the Coll-Exner bodies. Also in granulosa cell tumor, what is important is the presence of coffee bean nuclei. You have a nuclei with a longitudinal groove that is called as a coffee bean nuclei, correct? Then students, Leydig cell tumor when I have, then the patient will have Ringkase crystals, right? That is another thing which you need to remember. And when the patient has a Crookinberg's tumor in the ovary, it usually presents as a bilateral ovarian mass. There is symmetrical enlargement of the ovary. And what is Crookinberg? Diffuse type of gastric cancer metastasizing to the ovary, right? That is why when you see the microscopy here, you see signet ring cells, because in diffuse gastric cancer, I see the presence of signet ring cells. Easy story, students. So, Crookinberg's tumor, we see signet ring cells. So, this is basically a picture showing a lot of these cells which have a peripheral arrangement of nuclei. They are basically signet ring cells, right? This is the table which I have created for all of you. This is a very high yield table. A lot of MCQs can be asked from the students. Serous epithelial tumors will show Samoma bodies. CA125 will be the marker. Yolk sac tumor, Schiller dual bodies, alpha fetoprotein and alpha 1 antitrypsin positive. Teratoma, I have already told you. Choriocarcinoma, done already, beta HCG positive. Embryonal carcinoma will show primitive cells with no villi, CD30 and CK positive. Granulosa cell tumor will show Coll-Exner bodies and coffee bean nuclei. Sertoli cell tumors are inhibin positive. Leydig cell tumors will show the presence of Ringkase crystal. Dysgerminoma will show cells and nodules with fibrous septa containing lymphocytes. They are PLAP positive, LDH positive or HCG positive. Brenner's tumor will show transitional epithelium. Crookinberg's tumor will show signet ring cells. Very important table. Now, in the same paper, students, INI CET paper, this question was also asked from a ovarian or a testicular tumor. The image below is indicative of which of the following tumors. This was an image which was given, and in the image I could see a Schiller dual body, right? Now, Schiller dual bodies we all have done. These Schiller dual bodies are seen in yolk sac tumor. That is why the answer was yolk sac. Dysgerminoma would have shown nests of cells separated by fibrous septa infiltrated with lymphocytes. That was not there. Crookinberg's will show signet ring cells. That was not there. Granulosa cell will show Coll-Exner bodies and coffee bean nuclei. They are also not present. So, the answer here was a yolk sac tumor. Easy? Next. A 60-year-old woman presents with complaints of fatigue and dyspnea for 2 weeks. On examination, pallor was seen and hemoglobin was found to be 6 gram per deciliter, quite low. What will be seen on the peripheral smear? Now, a woman who is very old with fatigue dyspnea and very low hemoglobin with nothing else seen, nothing else given in the question, you will directly think about anemia, and which anemia which I normally think about iron deficiency anemia. Remember, students, I told you that iron deficiency anemia is commonly seen in chronic malignancies, right, in old age. So whenever the age of the patient is high, you have to think about iron deficiency anemia. Also, that can be a presenting symptom, right? Here the options were poikilocytes, not clearly, microcytic hypochromic cells. I would have marked microcytic hypochromic cells because they are the characteristic feature of iron deficiency anemia. The other options are macrocytic cells or target cells, not really. Target cells might be seen in iron deficiency anemia, but here, because we have to mark one option, best answer here is microcytic hypochromic cells, right? This is the DDs of microcytic hypochromic cells. This is how the image look like. Smaller cell with more than one-third pallor, and the DD is CETA, sideroblastic, iron deficiency, thal and anemia of chronic disease. We have done them multiple times, right? Then we move to the next question, students. The last question, a young boy who presented with recurrent episodes of melena. On examination, there was dermatitis-like rash on the skin with multiple petechiae. His platelet count was low, but RBC and WBC counts were within normal limits. Which of the following is a diagnostic investigation in this patient, right? Again, students, one of the examiner's favorite topic is Viscotald syndrome. This is a classic profile of Viscotald syndrome. See the keyword, students, a young boy with melena, dermatitis-like rash. The patient has a rash. The patient has got petechiae. The patient had decreased platelet count. This is the information which is given to you. Young boy with melena, right? So these are the important keywords. Let us see the options. VASP gene mutation, Viscotald syndrome, that can be the answer. Antiplatelet antibodies are seen in ITP. Do you think this is ITP? I don't think so, because in ITP what will happen? Why will there be melena in that patient, right? So it is not ITP. Why will there be a dermatitis like rash? You can't explain that. Bone marrow examination. When the patient does not have any pancytopenia, why will you do a bone marrow examination? Electron microscopy, again vague answer. Best answer here is VASP gene mutation, because this is the classical profile of Viscotald syndrome. Remember, I told you about Viscotald syndrome. It is a X-linked recessive disorder. That is why there is a history of a male much common than female. Here also it's a young boy, right? It is associated with VASP gene mutation. I have already told you. What is the triad? The patient has got eczema, the patient has got thrombocytopenia, and the patient has got thrombocytopenia, that is low platelet count, along with small size platelets. The platelets are very, very small, right? And along with the patient has got immunodeficiency. There is a T cell defect in this patient, correct? There is a mnemonic which I have told you about Viscotald syndrome, and that mnemonic is called as WAITER. You can remember by this. W for VASP gene mutation and Viscotald syndrome, right? A for age of the patient, that is quite young age. I for immunodeficiency. T for T cell defect. I for immunodeficiency, that is why there are recurrent infections. E for eczema. T for T cell defect, students, and thrombocytopenia. R for recurrent infections again, right? So this is the mnemonic for Viscotald syndrome. This was a classic profile of Viscotald syndrome. That is why what is the investigation you will do? That is a VASP gene mutation, right? With this, students, I finish off with all the questions from pathology which were asked in the INI CET exam. I know you must have done most of the questions correctly, because we have done all of them in our videos and the MCQ discussions and the rapid revisions, right? And if you have read pathology thoroughly, or if you have revised it at least twice, I'm sure you would have been able to answer such questions, right? My advice to all of you is that INI CET gives a lot of repeat questions and the repeat topics. That is why for the next INI CET, you have to pick up or make a list of these topics which are asked and then do those topics in detail, right? Thank you so much, students. Happy studying and all the best.